All right. Hello, everyone, and welcome to today's webinar, Rural Health Challenges and Opportunities. We are thrilled that you've joined us today. My name is Cassidy Avila, and I am the program coordinator for the Rural Engagement Program here at the Texas A&M Rural and Community Health Institute. A couple of quick comments before we introduce the speaker. We are recording a webinar today, and a link will be shared with the recording as well as the slides. You'll get that in an email from the Rural Engagement Program if you'll give us maybe 48 to 72 hours to get that out. We will definitely get that to you. And following the presentation, we'll open the floor for a Q&A session. You are welcome to submit your questions anytime in the chat, either to me directly or to the entire group, and I'll make sure that they're addressed during the Q&A. But now I would like to take a moment to introduce our speaker, Quang Ngo. Quang is the Vice President of Torch and the President of the Torch Foundation. He's been at Torch since the summer of 2006 and has had the privilege and joy of working on various strategic initiatives, including leadership development, health information technology, performance improvement, data analytics, telehealth, clinical integration, and finance and operation, and so much more. Before joining Torch, Wong managed the Texas Medicare Rural Hospital Flexibility Program at the State Office of Rural Health, where he facilitated the conversation of and developed programming for more than 60 critical access hospitals. I'm sure many of you know or are familiar with him, and it is a great honor to have you with us today, Quang. I'm going to turn it over to you. They're all yours.
Right, thank you. Thank you, Cassie. Let me pull my presentation, just find it. Here we go. All right, let me know if you can
Yes,
see the screen. All
I
right, and then that's right. Give me a second to see if I can.
we're almost there.
All right. Well, thank you again. Glad to be here. Um, I show this day because that's our last hospital closure in 2025 spring. And that's Mid-Coast Trinity Sad Day. This is the number of hospital closures in 2024 and 25, respectively. And earlier this year, the Center for Healthcare Quality and Payment Reform released their analysis showing 734 rural hospitals across the country at risk of closing, 84 in Texas at risk of closing, with 23 at immediate risk of closure in the next 2 years. This is important because in many ways it reflects our work and why it's so important for us to support rural health. Thanks again for the opportunity. Today, I want to kind of share a little bit with you about some of our work as we look at healthcare, why it's so hard, why it's so important. There are tremendous headwinds, but there are some tailwinds and cross currents in rural health as we speak. And so how we navigate the change and the opportunities becomes important. Who we work with becomes super important. I'm going to cover three things today. A little bit on the context won't overwhelm you, but what are some of the drivers of change that may cause challenges for our rural hospitals? And in that, I will share a little bit of our analysis. Every year we do a little bit of the baseline analysis on the performance of rural hospital. There's an in-depth version. Today I'm kind of going to share sort of the overview, touch on a little bit on the Torch Hub for analytics, because I think that's important resource for rural hospitals, both critical access and PPS, in terms of how we utilize data and analytics insight to chart a path forward. And then, of course, end with what are some of the opportunities going forward. This is a very historic year. Again, Texas is really big. Lots of good things about it, and we're super blessed and thankful for all the partners we have, including Archie. We work a great deal with them, as well as with our friends at the state office. and also at agency and other partners, who all happen to focus very strongly on rural health and how to stabilize rural health infrastructure. Rural health, as I mentioned, is very hard. But my thesis is that stabilization and growth is in fact possible. It's possible, but it requires strategic, coordinated, investment, cross-sector investments across both public and private sectors. Because y'all know this, in rural, the cornerstone of rural is that we're better together, and when we're working together, I think we can overcome some of these challenges. But our work has to be purposeful. There has to be an end in mind. And in many things, as we work towards solutions, form has to follow function. The how has to follow the why. So we do all this to position rural hospitals and rural health clinics to succeed, to stabilize, to grow, to thrive. It's possible, it's difficult. You also know that there are many tensions in rural health. If we do everything perfectly in rural health, um, we may impact 20% of health outcome. It's an unfortunate state of affairs that zip codes and where we live are better predictors of our health outcome. Um, but that's sort of the world that we live in. We also have a tremendous sort of tension between margin and mission, and we'll talk a little bit about this as we go forward. And of course, the root cause of most of our challenges begins with the fact that we're small, low volume providers, and therefore lack a lot of the scale and the ability to spread the fixed costs that we have to bear. A lot of my work focuses on hospital finance and operations, so I think a lot about zero and break even. And there's a interesting dichotomy to me. Zero, I think, is an absolutely right goal when we think about quality, right? High resiliency systems, zero harm, zero near misses. But I question whether zero is the right goal when we think about hospital finance. Is break even all that we can aspire to? Is that all that is possible? Surely we can do better. I think the other thing that's worth bringing up in the forefront is we also struggle with sort of the immediate challenges in front that may hamper our ability to aspire and to think strategically in the long run. And we also struggle because of the resource limitations, where to play offense, where to play defense. And so these are important notions and dichotomies that I think has important implications in our work. Texas is a big state, lots of rural hospitals, lots of rural health clinics, FQs, and other types of providers. Over the years, we've also struggled with a lot of different definitions that have important implications in our work. And this is many years ago. There are at least 46 rule definitions, many more today. Today, we have 55 rural hospitals by our county at Torch. Of those, 94 are critical access hospitals. Several others are trying to achieve that designation, but increasingly difficult since the sunset of the state ability to designate necessary providers way back in 2006. 388 plus clinics growing, which is encouraging because that's a sign of the importance of primary care and rural health clinics. Conversely, we are losing hospitals that have the ability to continue to provide OB services. And I think today we have about 64, 63 rural hospitals that provide that service. And y'all know this. Rural hospitals are pillars, economic foundations in local communities. Rural health clinics are vital primary care access points. And yet, there's significant underperforming across many providers because we're at such an intersection of multiple challenges and vulnerabilities. Many of our hospitals face real challenges in terms of being able to survive in the long run. There's also, for some years now, ample evidence showing that all vectors of change are pointing to a new imperative, one that is based on value, on outcome and patient experience, where primary care, preventions, efficiency, wellness is really what is being rewarded by the market and by the payment system. And so there's a real paradigm shift, a change in direction toward health and not just health care as a process, and a focus around how do we value and pay for outcomes, value creation focus and capabilities as a result thereof. I show this also because as we work with our rural hospitals and travel around the state, um, we get feedback, very important feedback, I think very instructive feedback around the challenges that are occurring out there. This is one of our hospital CEOs sitting in a room with their board chair. We were having conversations around sort of what's the future outlook for the hospital, for the community. And without really missing a beat, um, the CEO shared that really their strategic plan is keeping the door open and that they're really one mistake away from closing the hospital. I think this is sobering and it reflects sort of the challenge and the reality that they live with. And so when you're on at the, really at the edge of the cliff about to fall over, when you're dealing with the immediacy, how to make it to the next day, how to make the next payroll, for some, zero is a good year. It goes back to that sort of, where do we set our benchmark for success? This is one of our absolute favorite CEO, an extraordinary CEO, and yet that person's goal is, if we get to zero at the end of the year, that's a good year for us. I'd like to think that we could do better, that the system is not stacked against us, but we got our work cut out for us. I borrowed this slide from John Henderson because oftentimes in rural health, the challenge begins with definition and begins with the dichotomies that we have to deal with and the implications that follow from those definitions of dichotomy. On your left, that's not rural. That's the big city, urban. Um, on the right, to us, that's very rural. We happen to be driving by a rural hospital outside of Austin when you really see this kind of an image. Most people in federal government don't quite grasp the degree of rurality that exists here in Texas. Um, we all know that there are many challenges in rural health. Some might even say it's dysfunctional, it's broken, doesn't work. Lots of challenges. I'll summarize it this way. Um, uh, First and foremost, there's a tension in rural health that we see over the years working our members. For most rural hospitals and providers, they are high on mission. Want to do well. It's a noble profession. Want to take care of their communities because it's their families and neighbors and friends. Um, and we all know that the system is intricately tied to the overall health of the economy, where if one falls, the other will have a hard time surviving. But we also know that, profitability and the dollars they make doesn't equal the health of the community or the happiness of their physicians and providers. Most of the challenges directly or indirectly, unfortunately, lead back to finance. And so the overall health of the organization, we know on the one hand is greater than the money and there's not enough money to solve all the problems. And so, how do we reconcile this sort of duality of the economic and clinical consideration, which is to say that there's a tension between mission and margin? Want to do well, but we don't have the margin to support a lot of times continuation of the mission. How do we address that? I also think that healthcare has an agency problem, which is manifested in the sort of the tug and war between price and cost. Providers, and this is because a lot of the times providers and consumers that generate the expenses aren't necessarily the ones that pay for them, which cause the misaligned incentives that exist in the payment system, which then cause the dysfunctional market. What Dr. Rosenthal used to say, it's a dysfunctional market where prices will rise to whatever the market will bear. And so what we see is that hospital prices don't equate to or equal what patients will pay. And so on the aggregate national level, we see spending doesn't equal or isn't commensurate to the outcomes. And so at the same time, we see that the industry, this tremendous dynamic and movement industry with respect to mergers and acquisitions. And all that is really about the control of the price. Gigantism is about price control. What we also see from the data is that some markets have a price problem, but every market has a cost problem. And this is important because as we dig deeper into cost to charge ratio and the linkage between price and profitability, we see that there's a tremendous gap that exists between rural providers and their urban counterparts. And so the government steps in with transparency some years ago in an effort to control price. would shift focus from utilization to price. But the question becomes, at what cost? Oftentimes, in some of these policy movements, we see the results getting to the negotiated, mean, which isn't necessarily good for anyone. We also have a legacy problem in healthcare. We know that most rural hospitals are highly dependent on Medicare, but loss is baked into the cake. For those that track the Medicare advisory that advises Congress, and they put out MedPAC that put out their report. We're at an all-time negative margin with respect to Medicare. It's baked into the cake. Loss is baked into the cake. And in fact, they went further to say that if you are a highly efficient Medicare operation, there's a -2% loss. And so, as I mentioned, this puts us at a tremendous disadvantage. Rural providers highly depend on Medicare, but the payment system is structured so that you can't profit from it. Where you make money is actually on the commercial, and that's become increasingly more difficult. There's also sort of a market shift as we see over the years, that there's a change in the payer mix. Tremendous penetration in Medicare Advantage, which causes the erosion of Medicare, which for critical access that depend on cost-based reimbursement. That becomes problematic because the erosion of traditional Medicare will, I think, effectively over time erase the cost-based benefit for critical access and other cost-based providers like even rural health clinics. And so the idea around the M&A is that it shifts from a practice mindset standpoint. It shifts physicians and providers from being principals to now being agents of corporations. And that has implications around, profits, the way they practice and the productivity, even efficiency. The other major shifts is the inpatient to outpatient shift. So the change in payer sites, payer mix, will have a tremendous financial impact to the way rural hospitals are paid. All right, so that's a really quick overview of sort of the environmental structural things that are happening in healthcare that poses challenges to many rural providers. Um, every year, as I mentioned at the start, we take a look at the data that's available to us and look at sort of the performance of rural hospitals across the state. And rather than overwhelming you with a whole bunch of numbers, I thought I'd summarize it in a couple key big areas. The good news is that 63% of our hospitals show positive total margin. And so that, believe it or not, those are some of the best numbers we've seen in a long, long time. We've seen some numbers a little bit better than this following the couple years following the pandemic, but that's mostly because of the injection of the relief funding. Um, but that gives us some hope that hospitals are doing pretty well. On the other hand, there's almost 30%, 27% of our rural hospitals have less than 10 days cash on hand. This is a huge area of worry for us. And in fact, most of the calls that John and I receive at Torch, either on a Friday afternoon, always seem to be on a Friday afternoon, or Monday morning, is that a hospital can't make payroll for the next payroll, and that becomes a big crisis and SOS call, and we all scramble to figure out how we can help them. So days cash on hand for those that have very thin cash cushion, a tremendous worry for us. Days in AR, a lot of things in healthcare follows a bell curve. And for those that are doing really well, 14% of them, days in AR less than 30, do tremendous work. Acceptable range are between 30 to 45 days, and about 40% of our rural hospitals fall within that range. But then there are others who don't do well in this particular liquidity metric, and so we worry about that. We also know in recent this year in particular, Some of our rural hospitals struggles, in particular because of the vendors they're working with. And so we understand that. But in general, this is an area where, if we can't get the bill out, we can't the physician to sign off, we can't collect. I think that's an unfortunate place to be, and we got to do something to fix that problem. Um, in terms of acute average daily census, particularly for critical access hospital, low volume hospital, it's almost non-existent. And in fact, over the years, I've seen this decline to the point where it becomes very troublesome. I remember first out of grad school, one of my first assignments at the state office was to look at the average daily census trend for critical access in rural hospital. And back then, I was amazed at how low it was. Fast forward some, 20 years later, we're sitting at 1.3% in terms of average daily census. Very, very low. In terms of charge to cost ratio, do this again. Last year when we did this analysis, 1 in 5 rural hospitals don't charge enough to cover their costs. This year, a little bit better, 18%, under one, which means that, almost 1 in 5 rural hospital, all things considered, will continue to lose the more they do simply because they're upside down in the way they charge and set their prices. Um, 57% of all rural hospitals are located in markets that are shrinking. Very few, only a handful that I'm aware of are in growing markets. And so what this means is that we really have to fight hard to keep every patient in our market to serve them. The challenge becomes really, really difficult. As we also have the distinction of having very high uninsured rates in the country, and so y'all know that we carry a tremendous amount of uncompensated care burden collectively, with a median of about 3.4 million per hospital. All this adds up, and so 81% of rural hospitals have negative net patient services. This is stunning, and that's increased last year from last year's analysis at 77%. We just don't make it on patient care services alone. This is difficult to read, not intended for that. Just want to show you a visual of some sort of a longitudinal analysis of total margin separated by critical access, PPS, and REHs. Over the years, you can see there's a number of hospitals that do really well consistently. There's also a number of hospitals that do that struggle consistently over years. The variations in performance is vast, and the schism between the high performance and the low performance seem to have widened over the years as well. And then there's also tremendous variability among many of them year over year, which makes predicting sort of, margin unpredictability makes it really difficult for strategic planning. And so sometimes we need to dig into why there's such a tremendous up and down for so many rural hospitals. Just some examples of some of the things that some of the hospitals that don't that struggle over the years. And as I mentioned, wide variation over the years, margin unpredictability. A lot of the stuff happens from year to year. Makes it very difficult for planning. And we also see that great percentage of rural hospitals have experienced decline in total margin from year over year as well. All right, here's the graph of the operating margin, which is different than the total margin. So the good news is that 54 hospitals have greater than 10% margin. That's 34 over a little bit over a third of our hospitals are doing really well with greater than 10% positive total margin. On the flip side, we have close to 23% of hospitals that experience greater than negative 10% margin. And this seems to be getting worse over the years. And so the ones that are doing well continue to do better from year to year. The ones that are not doing so well continue to slip from year to year. The median in total margin is 1.1%. And so you can see that there are a handful of rural hospitals that are in the deep red, And then there's several that are doing really, really well based on sort of the spread of the operating margin. When you overlay the operating margin, the total margin, you can see sort of the differences in other revenue, non-patient revenue that makes up, most of the loss. Um, and for some, that's what they really depend on to get them over into the black. Here's the distribution of accounts receivable for Texas Rural Hospital, as I mentioned, in the bell curve. For those within the acceptable range, doing really well. For those that are not, really need to prioritize revenue cycle integrity and some of the cost containment issues. What we also seen is that while point of cash service collections have increased from year to year, we've also seen receivable days increase from year to year. And that's primarily stemming from increases in denial rates. A lot of that is coming from Medicare Advantage. And we see those type of AR increases greater than 90 days, not only for Medicaid, Medicare, but also across other types of payers as well. Here's today's cash on hand. Um, and again, this is the thing that we pay a lot of attention to. Um, Realizing that there are some caveats in how cash is being handled, the difference between how cash is handled between small rural hospitals, independent hospitals, and big health and big systems, which tend to maintain pretty low cash reserves. And from a data analytics standpoint, often we can parse out for those small hospitals that are part of big systems, they how they handle cash because a lot of that is handled at the system level and not at the individual facility level, and so you can't see that. But nevertheless, for those small independent rural hospitals that have very low thin cash cushion. We worry a lot about those. For those that are well flush with cash, sometimes it's an issue around potentially underinvestment. And for those that are fortunate enough to have tax support and in areas where there's lots of sort of oil booms and things of that sort, they do pretty well. I shared a little bit there on the um, some of the summary of what it means if you're struggling from a cash position standpoint, as well as if you're doing well from a cash position standpoint. Outpatient revenue to total revenue. We like to map this and take a look at this because, as we know, over the years, tremendous dependence on outpatient revenue. And so today, what we see is between 80 and 90% of rural hospitals um, have heavy dependence, where a big part of their total revenue comes from outpatient. And so what this means is that there's with the shift in care sites comes a shift in payments. And so there's some strategic implications for that. In the industry, the strategy is to invest not so much in beds, but in capabilities in outpatient type of focus setting and services, and convenience. We also see that critical access are typically less diversified than their PPS counterparts, which tend to be generally a little bit larger, and because they're larger, have more capabilities to provide more intensive inpatient services. But when we see overall this trend, this continued shift from inpatient intensive acute care to outpatient, more convenient-based type of care, what this really means that over time, rural hospitals or hospitals in general are no longer really hospital in the traditional sense. And in fact, many are beginning to look like from an operational and from a data standpoint, more like outpatient centers based on their book of business. And in fact, as we run some of this based on the new REH, many of our acute care hospitals today, in fact, look and behave and operate as if they are rural emergency hospitals without the benefit of the rural emergency hospital payment. Distribution to charge to cost ratio. Here's the sort of the graph that shows what the point I was making earlier. About 12% have charge to cost ratios less than one, and in aggregate, 18% less than one, which means that you don't cover costs um, for the critical access don't cover costs. Um, and so the more you do, the more you market and get patients into your facility, the more you lose on that from that respect. I'd be remiss to not talk a little bit about the Medicare Advantage threat, which is profound. Um, the growth of Medicare Advantage today is about 54% nationally, which is about 32.8 million of all the Medicare beneficiary. And this really has been driven by a combination of policies, starting with the MMA in 2003, which had created strong financial incentives for growth, for MA growth, as well as the profit margin. Just to give you a sense of why everybody is focusing on MA, it's because as we look across the last 10 years or more, the average stock price increases for MA is something like 825% for the top five insurers compared to the average stock market. And so there's tremendous money to be made in MA, and that has been sort of the big driver for penetration. The impact, of course, is that as the payer mix and the market share for MA continues to rise, it will erode the traditional Medicare, which means the potential loss of cost-based reimbursement for critical access hospital, and eventually will erode, will erase sort of the whole benefit of critical access to begin with. The market concentration and the rise of the narrow network combined with the steerage that's happening in many of the MA plan, not to mention the increase in IOs and out-of-pockets and pre-authorization, all this has a really negative impact in terms of access for the patients. And so it's a tremendous, profound impact. I'm not sure there's much that anyone can do about it. There are glimpses of hope as we watch large systems begin to drop the Medicare Advantage plans. So all this, and I should have apologized from the beginning. For those who know Dennis Thomas, he once said that I'm always sort of Mr. Doom and Gloom, and I like to think that I'm more of an optimist. But there are some real challenges as we've seen, and a lot of these financial and operational challenges all come together to give a very grim picture as we look at, and this is not just this year or the year before. This is as we look across the last 12 to, in fact, 15 years, we've seen consistently this kind of graphs where about 80 or more percent of our rural hospitals are losing on just patient care services. If not for other things that can help bump them up across into the Black territory, everybody virtually is losing on healthcare services to the aggregate tune of about this last analysis, 480 million um, in net income loss from patient services across all rural hospitals. Last year, it was about 279 million, so we've tremendously gotten worse. And that's a picture that I worry a lot in terms of what we do. And so what does all this mean? At a very high level, we see a couple of strategic options, the worst of which working from bottom up. The worst of which is that we see rural hospital closure in Texas is ground zero for that. We've seen too many hospitals close over the years. More will continue to close. We've also seen, luckily, with the availability of the REH status, several hospitals, four in Texas now, with a couple more pursuing, being able to capitalize on this step down, right? Become no longer the acute hospital, but taking on the REH status to serve the community. We also see concurrently a lot of affiliation taking place. That's not to say that it's all necessarily bad. In many markets, that's the best options that they have available to them to survive. But what that means a lot of times is their loss of independence for that community. The best option we think is that we have to find a way to integrate and work together. Not so much financial integration, but clinical integration um, to be able to leverage the cover lives, aggregate the provider network, and expand our coverage reach or geographic reach in order to jointly negotiate. It's the one options available to us, the CIN, that will allow us to overcome the small numbers challenge and, in fact, be able to work together legally and not violate antitrust laws. All right. A little bit into the theory about so what do we do about all this? For years, as we talked about value-based care and the movement toward value-based care, I'm convinced that we cannot get there successfully if we grow up in the dark without access to analytics that gives us the ability to see where the opportunities exist. Since the summer of 2020, during the height of the pandemic, was blessed to have funding from the state office to create and jumpstart and launch the Torch Hub for Analytics, which I'm proud to say today, all 155 rural hospitals have access to this data resources at no cost to anyone. If you haven't gone on recently, I encourage you to do it. There's tremendous opportunities and insights that can be gained through the data there. A lot of work over the years. I want to acknowledge the SOAR for funding to support the critical access of the rural health clinics. And we're working to finalize to continue the contract with HHSC to extend that resource to PPS hospitals and the REHs. Also, we're super proud to be working with Lucky Dog Analytics over the years to build this from grounds up. The platform that we use is called Esri ArcGIS. It's an integrated geospatial mapping and analytics platform. And essentially, we create secure websites for everyone so that you can log in securely to your own data and begin to work with them. And so it's hosted on the Torch Hub for Analytics site there. For those who haven't been on or forgot your password, all you have to do is reach out to us, and we'll certainly get you back in. Our work is guided by some principles, and I won't go into that. Just know that our work is very focused. A lot of what we do begins with working with you to define your service area, whether that's the primary or secondary or strategic developmental area. And we encourage you to do that every so often, especially around strategic planning time. But once we define the service area, which will kind of take into account where the analytics will show you, is that we build out a few dashboards that you can utilize. To me, the first two dashboards, the market share and out-migration, uh, sort of two sides of the same coin. Obviously, market share is what you capture. Out-migration is what's bypassing your facility, and we have data. Most importantly, not just inpatient, but outpatient and ED. Remember what we shared earlier, that most of your book of business these days, from a revenue standpoint, is outpatient. Most data programs out there only have access to inpatient. We're lucky here in Texas. We collect very detailed data. And so after we curate and normalize the data, we're able to show you outpatient level data as well as emergency data. It's important for you to know sort of, how big your market is, who's competing with you in it, who's working with you there, how much of that do you capture versus going somewhere else. Out migration, put it simply, you can go to your out migration dashboard, be able to see who's leaving the market, where exactly they go to, down to the doorstep, and for what service. There's really no guessing at that point. Most of you know that there are degrees of leakage and bypass. Most people, however, are surprised at the degree and the magnitude of the out migration that they're experiencing in their market. I encourage you to go take a look at that. And then we also built in some tools to allow you to kind of look at profitability for some of the key things you do, beginning with imaging and emergency department. And then we also have built some opportunity analysis tool that will help you with strategic planning in a way that's data driven. Through the opportunity analysis tool, it's built in such a way that you have very robust filters that allows you to do different kinds of scenario planning. What we also saw from people using this tool early on is that in rural health, we often find that we're low volume, don't have enough volume. And so to the extent that if only we have more volume, we would be better. But in fact, the data shows, and for many facilities, the more you do, the more you lose, as I mentioned before. Why is that? It's because in many cases you haven't solved the underlying issues. There's some underlying issues that you need to address. Otherwise, it affects your financial performance as you increase that utilization. We also have created what's called a hospital two-pager, but really it's an executive summary of your performance. It's your performance profile, and we have that available for both hospitals and rural health clinics. Um, we summarize all the dashboards and all the things we have into essentially this executive view, a two-pager. There's two versions of that. One, the online version is interactive. You can hover over things, click on things. It shows you trend, 4-year trend over time. It's interactive. We also have a printable version, which isn't interactive, but allows you to kind of take a look at that and share that with your team. We've leapfrogged over the sort of contract and workforce bubble, and last year produced a performance index. Through a contract with HHSC, we were asked to develop a hospital vulnerability index. And so some of you have sort of heard a little bit about that this year. We weren't allowed to talk much about it, but essentially the purpose of that index was to utilize sort of a multifactorial view, 20 metrics across 4 domains, to really analyze and rank hospital performance. I will say a couple things. One, is it is our first best effort. We did not intend to go out and develop a mathematical model. We developed a model that fits our observation understanding of the sort of the working reality and the challenges of our rural hospitals. It's a sort of a capture point in time, and it's not predictive. Before I go too deep in that, because I think I have a slide on that, the other things that we have is what's called a financial and operational benchmark, 22 metrics across 6 financial principles from profitability, liquidity, capital structure, all the way to uh, utilization. There has been some new metrics introduced on UC, reinvestment, and Medicaid mix. But they pulled that off. National folks did, I think, because there's still some work around, defining those metrics correctly. So we're working in tandem as those metrics are released. We'll integrate those into our tool data set. So this is the vulnerability index for those who have some questions around it. As I mentioned, 20 variables across 4 domains, 10 around finance, 4 in operation, 3 each in around the market, competition, and community. These are we incorporated multi-year data into a lot of these, weighted them, did correlation against them, and so ultimately we produce an index that ranked the hospital's performance. Um, um, of importance is that when House Bill 18 was passed, it codified the use of the index at HHSC, using the index to identify those tiers of hospitals that would be at risk, that would benefit from their funding. And so, as you all saw earlier this year, the index ranking will be used to direct funding, stabilization funding to hospitals. So I encourage you to utilize the hub as and begin to look at those opportunities for improvement, because it will continue to be used by HHC to direct funding for stabilization in the years to come. We're actually in the process of finalizing the contract to provide the update for them, and their expectation is to bring that index in-house to HHSC and begin to update that themselves following this next cycle. So the data is important, and I think it's awfully revealing and powerful, but it's no good unless somebody uses it. And I know use is at times struggle. Not everybody wakes up jumping out of their seat to look at data every day. But to the extent that there are initiatives you want to chase, and activities you want to do, I would encourage you to take a look at that. Here's a sort of a sampling of use cases across different areas that we've captured over the years. And behind each of these are numerous hospitals that we've helped with on some of this stuff, whether it's from strategy or leadership onboarding to service market line growth, to contracting workforce, you name it. The data can be very powerful and can help you with that. So again, I encourage you. Hope this list kind of gives you a sense of all the different things that people have been able to use the data resources to chase. To the extent that you have important questions or initiatives like that, and we can help, please feel free to reach out to us. Won't cover this. As I mentioned, I'll, work as we kind of follow this form follows function. We're very mindful around sort of the why we do a lot of this, and that's the mechanics. But really sort of our main aim at the end of the day is, what's the outcome of all this? How can we put data to use? And to stimulate collaborations, and then tell the success to the extent that you're able to make improvement. Um, as I mentioned, I think it's worth kind of reiterate that the partnership is incredible. Encourage strong use across all the tools that we have. It's now available to everybody, and I think that's pretty cool. But the caution is there as well, that while the data can be powerful and illuminating, there is some sensitivity around how we use it. And even with the index, it's a capture, it's a point in time. Directionally may be instructive if big things don't change, but it's certainly not predictive. And the data can be very complex and nuanced. So you got to really understand the in and out of that as you use it. It's also important part of the big story, but not the whole story. And so we realize that some people say, well, this that the data doesn't say this. Well, of course, because there are many things that go into overall performance beyond just the analytics and the quantitative stuff. And so the gray areas where I think we rely on you to know how to use it. We rely on the proper technical assistance and consultation to know how to make sense of all this. But at the end of the day, the call to action is please use it. It's an important data set. We're lucky here in Texas that we have partners and resources to help provide this to everyone. All right, let me summarize, and then I'm going to touch on the path going forward. Of all the things happening in healthcare, I think I could summarize that there's two big concurrent seismic shifts going at the same time. On the one hand, there's sort of a converging of ecosystems that's happening, and not just in healthcare, but in industry, technology, life sciences, etc. And all that convergence and vertical sort of merger of systems is and capability is that it effectively redefined markets and effectively redefined how we access and the role of providers themselves. Much of this is a lot of components of this convergence happen at a global level, right? Which is distinct from what we used to know and say that all healthcare is local, which is still true, but a lot of the drivers, a lot of the capabilities now is driven at a global, beyond local market area. Remember, gigantism with respect from merger and acquisition is all about price control. And so that has real implications around autonomy of practices, principal versus agents, payer versus providers. The lines are very blurred. That's the convergent side. On the other side, there's also concurrently a decentralization where, big hospitals with expensive, costs and fixed costs and equipments, trying to stuff patients through them as quickly as that's becoming quickly an outdated model. Today, driven by digital innovations, the social connectivity, the mobility of people, the fluidity of data, and now, of course, the power of AI. A lot of that is now driving access in such a point where it redefines a hospital. As we mentioned before, no longer is, most of the services are in the inpatient acute care setting, but increasingly migrating to the outpatient, all the way to anywhere care to the home. And so today, preventing readmission is the key. Tomorrow is preventing admission altogether. It's the notion between hospital versus health. And so, as this trend continues, we see increasing commoditization of healthcare. You see that in the big box retailers, where they try to capture everything in one place through convenience. But ultimately, I think the trend continues to democratize healthcare itself, so that everyone, from a patient perspective, who have access to information, to data through things like mobile phone, can then begin to participate meaningfully in their healthcare. It's something that uh, you know um, the CEO of Apple would say, if they were to zoom into the future and look back and say, what's the biggest contribution of companies like Apple? It isn't really the latest iPhone or the latest Mac. It's really about how do these tools democratize healthcare, enable people, empower patients and people to to be an active participant in their healthcare, and that's a powerful trend, and I think that's something we need to really pay attention to because that's where the future is heading. All right, let me summarize. And so the challenges are real. There's many of them. There's a confluence of them. But we also know that rural is not just more versions of urban. We face many challenges, and and they're real. On top of that, healthcare is, unlike other traditional markets, hospitals aren't monolithic. There are lots of differences in the way they operate, and their outcome in terms of profitability. And that could be tempered or exacerbated by a complex mix of many factors. I still say that as we look at the industry for some years, headwinds continue to be largely around externalities, but there are things within your control, as I mentioned, through the use of data, we can see. But all this leads to many to an existential risk where really, they don't know whether they can actually make it to the next day or not. And unfortunately, we get a lot of those calls at the torch office. And so let me end by saying that, today the challenges are real, but we also have a focus problem. And the focus problem we see manifested in, being bogged down by the immediate challenges that's in front of us, not allowing us to aspire to a better future. And this came to light, I think, most clearly a year or two into the pandemic, when we work with some really bright folks to have strategic conversation with our members across the state. And one of the first things that came out from a lot of those conversations is that many of our members, particularly those that are struggling, let their past, present, and future be defined by reimbursement or lack thereof. Can't think beyond because we're so bogged down by the challenges of today. But I also say that we can't cut ourselves, to sustainability. We're already lean. We don't have a lot to cut off, and so it's difficult to get to sustainability by just cutting costs. In an environment where there are very strategic opportunities before us, strategy is definitely not that place to cut. So what is the path forward? The path forward, I think, is the recognition that the future is about health. There's an important paradigm shift happening in healthcare, where we're focused on a health and outcome. And it so happened that primary care is a big part of that future. And it's critical to that piece. And the good news is that we're well positioned in rural to do well in primary care. The margin of excellence isn't about more processing, but about outcomes and patient experience. I would say that grow revenue, but beyond grow revenue, it's really about growing trust, build that loyalty and engagement with your community because it will reap dividends. Leverage data to the extent that you can look at data to match strategy to demand because we don't have the resources in rural health to grow up around until we get something right. And so leverage data, be strategic. Um, with respect to technology, strategy first, technology follows. Use technology to unlock access to markets and to improve efficiency, but you got to understand what you're trying to use technology to get to. And then we can't do it all. And so at the end of the day, reinforce core fundamentals, control what's controllable, look at expenses, look at leakage, manage the risk. A lot of this stuff is tied up into the revenue cycle integrity functions. And so you got to really have a good handle on that. And of course, invest in your people, invest in your talent, and build resilience and agility over time. What John has always said is we can't just aim. At some point, we gotta hit. We can't just play defense. We gotta play offense. It's an incredible historic year in terms of investment in rural health. Never before have we seen this level of investment, both at the federal and at the state level. Remember that the state actually passed House Bill 18 before the One Big Beautiful Bill. And so there's tremendous investment at the state level for rural health, about 124 million, 23 million rural stabilization funds, and that goes to the two lowest tier performance based on that index, which is about 79 hospital. And then there's also a creation of an innovation fund at the state level. This is House Bill 18, 50 million biennium, which means 25 million in innovation fund every year. For those who may remember, we're hosting a Rural Hospital Innovation Summit on April the 13th ahead of our Torchman Conference. And the reason for that is we're trying to stimulate some thinking, exchange of ideas, and kind of tee up conversations in preparation for the innovation grants that will be coming out through HHSC. We don't know a lot of the details, which hasn't been revealed to anyone. But indication is that they're going to fund at very high level in the millions. But that means fewer applications funded. But this is happening every year. Um, and we think that the application will probably come out in the early summer. So it's going to be a quick turnaround. We're going to have lots of conversation there. Encourage you to make that summit if you can, participate in the conversation. And then afterwards, we're going to talk a little bit about next steps in terms of technical writing, grantsmanship workshop. There's also a $10 million allocation for the telepediatric connectivity through House Bill 18 as well. At the federal level, which is where most people are focusing their attention, as you know, Texas was awarded 281 million per year over the next 5 years, which is about 1.4 billion over 5 years. HHSC has been very diligent in staffing up their office. They have hired a rural transformation office director. Person's name is Anthony Hawley, and also two managers who will work with that director. Um, um, Trent Engeldow, who used to be the state office director, is also one of the managers, and Joy, who is the other manager. Each of them will oversee three initiatives, and they will also staff up other grants management people in there as well. The Rural Texas Straw application, sixth initiative, as you all know, I kind of summarize it there. For 2026, most of the attention will be around Initiative 1, and then that will be a direct intergovernmental contract to 80 hospital districts. I know John sent out a hospital list, a list of 80 hospital districts, and we've gotten lots of feedback on people who aren't on there. That list is not the correct list. HHSC does have a list that they're working on. They haven't released it. We're also working on a list and make sure that we can reconcile the final list that comes out. But word is that 80 districts with a hospital will be the one receiving direct contract through HHSC for Initiative 1. Dollars will flow around Q4, which is anticipated to be around October. It's the biggest amount of money of all the six initiatives. About 31% of the funding requested will go to that initiative. That will come out this year, sometime in Q4. We we know that HHSC submitted the application, the revised application to CMS in February. We anticipated that the state would be funded around March and with money flowing to the provider in October. As of last week, CMS has not yet um, approve the state revised application, but we know that's coming. And as I mentioned, most of year one will be on the MAHA initiative with dollars flowing directly through intergovernmental contracting. Initiatives 2, 3, and 5, which is more tech heavy, look to CIN, ACOs, network with leverage, and that will continue in 2027 going forward. HHSC is expected to administer the first one, the workforce, the one involving cybersecurity, and the one involving capital equipment. For the others are obviously all rural providers in the 202 rural counties. Those include hospitals, FQs, rural health clinics, behavioral health, you name it, EMS, pharmacy. All those providers will be eligible. I think we anticipate that in most cases, the hospital districts may take the lead. And where there aren't hospital districts, of course, we encourage people to work at the county level. So I know that's very high level up. We'll continue to share information around rural transformation as they come out. But I wanted to kind of give you a quick sense of where we are today. And I think that's wraps it up for me. And I'll pause it to see if anybody might have any questions.
Great, thank you so much. If you have any questions, we are at the top of the hour, but we will hang out if you have some questions. We would be happy to take those. I'm checking the chat and I don't see anything, but let me just make a few announcements. And if you think of something, please unmute or drop your question in the chat and I'll come back to it. But I just wanted to let you know that if you have any questions around anything that Quang talked about today, any of the tools or resources that were discussed, please reach out to him or us and we will make that connection for you and get you the information that you're looking for. The links that I dropped in the chat will allow you to gain more information about the Rural and Community Health Institute and how we may be able to support your rural facility. And then also, if you're interested in any technical assistance that we might be able to provide. I'm also going to launch a poll real quick. It's just a few questions. Okay, I launched that. And let me go back. I thought I heard something, but it wasn't the chat. Okay. So I think that's all that we have, unless anyone is in the process of typing their question. I'm going to go ahead and stop the recording.